ability to work and to be a contributing member of the community. That's what everyone wants to do. And our safety net and the people that are here today are a large reason for our ability to help provide those supports. When we look back and we go back to where we were before with Health and Human Services and providing a safety net, medical safety net, particularly as it relates to health, primary care, we were engaged in that and we did that very well. But we also knew that a strong safety net for Health and Human Services also meant that the community needed to have a strong investment in that, and that the community had a strong role in assuring that that safety net was there, because it isn't just the responsibility of one organization or one group. And this panel today, very large panel, is going to talk to you about their particular role. And what we tried to do is to say, here are the partners that provide the services, the direct primary care or other medical services. Then we'll talk about the people that help them in those support services, whether that's medication assistance or behavioral health, accessing behavioral health services. And we'll talk about those supports that are there that help people get the means by which to either provide payment for those services or to provide insurance programs to cover those services. And then finally, we'll talk about the role of care management in those services that works to get the best outcome for the patients and the community, but also helps to contain cost and helps to mitigate some of the very high cost patients that many of these safety net providers are seeing today. So that's how we'll sort of break down the safety net. The thing that I wanted to tell you also is that from a Health and Human Services perspective, of that almost $500 million in total community services and benefits that we administer directly for the services that we're talking about here today, the county contributes close to $3 million in direct services, and then an additional almost $800,000 in in-kind services in the form of space that we own and that we allow providers to use for $1 a year. So there's a large contribution that the county management board of commissioners has invested within just the medical arm of what we're talking about here today. So I'm very grateful for the participants today. So we'll start off with Carlos Gomez with Western North Carolina Community Health Services to talk about the services that they're providing. And then please, as we go down the aisle, if you'll introduce yourselves and tell what particular area of the safety net you're working with. Thank you.
Thank you, Jim. And it's a hard task to do in 5 minutes, but we'll try. So I brought some handouts, and so I won't bore you with everything, but I don't think there's enough for everybody in the room, but I just think for members of the board there are. So as I understand our task today from what Jim explained is that we're here to educate, especially the board plus the members of the public, on resources that are in place for healthcare or in the safety net. And so of course we need to talk about ourselves. And then specifically, we want to talk about the services and numbers of patients that we serve. Lastly, we want to talk about all the collaborations that we engage in because, as Jim said, primary health care, even conceptually, cannot be carried out alone. It must rely on strong referral systems with strong partners, and really supposed to be intersectorial. It doesn't, there is no such a thing as just health and nothing else. It impacts almost every aspect of the community and of life. So, so collaborations are essential, and so I will give you a brief synopsis of our history and how we got here for those of you who don't remember. Although I see a lot of people on the board that do remember, should remember us. Then Dr. Wallenius will talk about the rest of what we're doing. So Western North Carolina Community Health Services began in the early 1990s. And if you remember what was going on at that time, the social political context of the times were the first attempt at healthcare reform, which failed, and also the HIV/AIDS public health crisis. And believe it or not, at that time in Asheville, there were people who were influenced by the Health for All movement. I don't know if any of you have heard of that, but we were certainly involved in that. And it was mainly a movement that views primary health care as a universal human right. So about 3 of us decided that we were gonna walk the talk. So that was Dr. Polly Ross, Ms. Minnie Jones, and myself. And so we began our organization. We started in the back of the Kenilworth Presbyterian Church in 1994 as an HIV/AIDS clinic, and now you'll hear what we're doing. Let's see, part of our initial motivation and involvement was to bring resources that were not in the county at the time for primary health care. So we organized specifically to become a community health center, and also to attract Brian White dollars into the community, because that was the special passion of Dr. Polly Ross. So I'll leave it at that.
Mm-hmm. And so I am Todd Lenius, and I went to medical school at Chapel Hill, where I was introduced to safety net medicine. I was nurtured by MAHAC Family Medicine Program, and really have matured over the last 15 years at WNC Community Health Services. And I'm proud to say that having gone from 50 patients when I entered services there to now serving, in your packet you'll see 16,000 patients this year. That's been quite a tremendous amount of growth that I've witnessed during my tenure there. The services that we provide are core services of medical care, integrated behavioral health care, and dental services. We have 13 full-time equivalent primary care providers at our clinic, and to serve those 16,000 patients. 15,000 unduplicated patients receive medical care, about 922 behavioral health care, and 5,000 dental care. In addition, we have enabling services that include case management, transitioning patients from the inpatient setting to the outpatient setting, providing eligibility assistance to patients, making sure that they are able to access all the resources that are available to them. So we were able to provide that to 7,500 of our patients. If you look at who comes to Winch's, it's important to note that only 13% have Medicare, 18% have Medicaid, 4% have commercial insurance, and that leaves 65% who come to us and have no form of payment. And so in providing these services to this safety net population with very few resources, 98% of that 16,000 are under 200% of the federal poverty level, 87% are under 100% of the poverty level. These are people in need. I'm proud of what we are able to achieve. And so I just want to run through a few of the performance measures that we've been following. The number of prenatal care patients that we've served, 471, of which 78%, 79% entered in their first trimester of care. So we were able to get them into care early. 204 deliveries in collaboration with MAHAC Women's Health. And of those, almost 93% had good birth weight outcomes. We had 43 children who became 3 years of age this year, and we were able to fully immunize about 80% of those. Of our 4,200 patients with hypertension, high blood pressure, 65% were able to control adequately, and when we compare that to Healthy People 2020 goal of 61%, we're doing fairly well. We have room to improve. We have about 2,000 patients living with diabetes, and about 71% of them are below a hemoglobin A1C of 9%. We have room to improve. Healthy People 2020 wants us at 84%. So we have quality improvement programs around that. And of the 718 patients we serve that live with HIV, we have been able to get 83% below 200 copies of virus per drop of blood. And our goal is to get at least 75%. So with the resources that we receive, I believe that we're able to do an outstanding job providing care to people who are at greatest need in our community. And we couldn't do it alone. And I attached for you to be able to look at in your spare time, because our time is running out, efforts that we make to make sure that we have those connections with other participants at this table and those who are not at this table, so that we don't let these most fragile of our neighbors fall through the cracks. Thank you very much for this opportunity.
Mandy, is it fair to ask them what portion of that budget comes from the county? Is that something that we would? I just want to, before I do, I want to make sure that it's an acceptable question.
They may or may not know right off the top of their head.
So I see I assume the county is in the contractual allowances portion of your budget.
No, actually, on the budget, and that, I meant to go over that, but, so that's the budget for, our total budget for this year, 18.7 million, and, this assumes a balanced budget. So, which it will be, or we'll hopefully have a little bit left over to put in reserves. Contractual allowances are what we, write off because the insurance companies won't pay us. So those are things that are beyond our charges. So Medicare says our charge for a visit is $50, Medicare may pay $20. So that's what that is. Sliding scale is the value of services, the cost of services to uninsured patients. And to insured patients who fall below the poverty line and are within our income guidelines. Patient-related revenue, which is about 65%, is what we actually get from Medicaid, Medicare, the little bit of health insurance, and sliding scale patient fees. The subsidized support is where the county contribution comes in, the federal contribution, and so on. So from the county this year, we will get 2.6 million, and from the federal government, 4.1 million. And part of our, the federal grant, it doesn't just come from one part of HRSA. We get HIV funding and we get community health center funding as well. We are a fairly new community health center, having gotten funded in 2007 for the first time. And so our federal grant is comparatively small. Definitely very small to the number of patients that we serve.
One other, I'm trying to get a handle on all of these agencies. So do you calculate what you potentially save the county or save the medical community by having your services available to you?
I don't calculate that. I don't have enough skills to do that. You know, we're not an economist that, you know, we don't have
I just-
but, so the best I can tell you all is the historic, you know, I'm an accountant, so, you know, that's historical, what you see there. And so I'm sorry, but I'm
It's
not
okay,
able.
I'm fine with that. I see the Versar standing up back there.
Well, one of the reasons that, one of the many reasons that we contract with the FQHC is because the reimbursement stream for an FQHC is much more robust. The federal government does a cost-based reimbursement system, and we can't compete with that. And so that allows those dollars to be used to cover the cost for care, as well as to be used for the uninsured and underinsured as well.
So what we're saying is, you can't really say how much we're saving, we're just getting more bang for the buck as far as the amount.
In one sense.
Right, so the county invests in direct federal dollars, it's 2-to-1. For every county dollar, we get 2 federal dollars, plus the enhanced revenue in fees from Medicare and Medicaid.
Okay, thank you.
So I'll move along. I'll try to keep us on schedule. So I just want to give you a little bit of background. I'm a physician. I practiced in my early years in a rural area, remote or rural area. I practiced in Kenya, worked in remote clinics in the north of Kenya, and I spent many years working in a rural clinic and health system in Honduras. I did see a patient at a clinic where the patient had a terrible abscess in her tooth and was unable to get the care that she needed. And eventually that abscess ended up forming an open abscess in the middle of the cheek that then drained externally. Just a horrible thing related to poor care. The problem is it didn't happen in Kenya or Honduras. It happened here in Asheville. And I saw the patient at the ABCCM clinic, in the free clinic. And so, you know, I love statistics, I love data, but it's for those people sitting around this room who are involved in the same kind of work, those are the things, it's one person at a time which motivates us to do what we do. It's the kind of thing that makes you realize that behind each of these statistics that they talked about, for example, is a real person. And you take this woman, she couldn't work. It's not that she could actually work behind even a desk at Target with that kind of deformity or pain. So there's many reasons why a community we should feel obligated. So I'm first of all really grateful for those of you elected officials and those of you that are volunteering at this board who have many other busy things to do. I know why you do it. You do it because you've had somebody's touched you to make you realize how important this work is. I must admit at MAHEC at times, I'm overwhelmed. It is an overwhelming prospect when you think about trying to provide care for so many people in a system, in an area that basically has decided that a certain percentage of our population just doesn't need to get care. And it's an overwhelming job, but I appreciate that there are many of you who are doggedly working in this area. Just a little bit about MAHEC. MAHEC has many roles, but one of our big roles is actually around primary care and actually safety net care. So MAHEC currently now has 9 of our own practices, and we manage 26 primary care practices for Mission Hospital. They're all across the western part of the state. There are a lot of heroes out there doing this kind of work, seeing patients every day, you know, working really hard to try to do as much as they can with what resources they have. A large commitment from MAHEC physicians and Mission physicians and Mission Hospital to try to, you know, do as much as we can to make that work. All of us here that are going to talk to you today, we all have many relationships. We work with each other because we have to, and we try to be efficient as we do it. Some of the areas in MAHEC where I think that we have a significant role, in addition to primary care, One is obstetrics. So in obstetrics and gynecology, we do about half the deliveries at Mission Hospital. We take care of all the high-risk care in Western North Carolina because we have 4 high-risk maternal fetal medicine docs whose job it is to take care of the most complicated patients. And as you might expect, those are not those people who are covered by Blue Cross Blue Shield and work in high-paying jobs. Those are patients that have lots of challenging social issues that make it difficult for them to get their care. We have actually tremendous outcomes and great support, from our partners that help to get those patients receive the kind of care they do. But it is very challenging. The state just decided that made it more difficult for undocumented people to get any coverage for health care. So now we are taking that on ourselves to try to provide that care without any pay. In another area, you've got Ed Crail on your board, so he can tell you, but Ed works for MAHEC as the head of our dental area. We see a lot of patients in the safety net area with very complicated problems. And then a new area that we have done in partnership with the county is around those very challenging patients that come from the ED, from the emergency department and from the hospital, who have had multiple frequent visits, and primarily because people don't get primary care for 2 reasons. One is because they're not paid to do it, but the other thing is it's complicated. It's hard to get appointments. It's hard to know, like, who do I see? The healthcare system is a maze. I mean, I've got a highly educated group of children, my own children, who are no dummies, and they still have to call me and say, Dad, like, something's wrong. How do I get into the healthcare system? Like, how do I do this? And so if my Harvard-educated kids have a hard time doing that, then what about if you're unemployed and you have a low-paying job? That it's really challenging. So I'm going to have Dr. Crane, who's the genius of great ideas, going to tell you a little bit about one project that we have with the county. Just one.
So I'm also a family doctor, and Dr. Heck and I actually have been practicing almost about the same amount of time. Originally, my first practice was actually up in Madison County, taking care of a rural population, and actually I was the first medical director of Blue Ridge Community Health Services down in Henderson County for a number of years. And most recently, and this is probably because I'm a round peg in a square hole probably anyway, Dr. Heck has actually given me the role of actually trying to find medical homes for those other square pegs. And so he talks about the issue that how difficult the healthcare system is. Even if we had a perfect healthcare system that worked for almost everybody, there are some folks it doesn't work for at all. Mainly because there are so many other complicated social, behavioral, medical issues they have. They are overwhelmed. And people who try to take care of them are often overwhelmed because there's so many pieces to connect. And that's where I live. That's what I'm trying to do, is to try to find the 500 or 1,000 people in a population of 65 to 70,000 people who don't fit in any of the holes that we've created. And so one of those projects is we call the Project 1300, which is actually a combination of looking at the homeless primarily that don't fit in many pegs right now. And then the other piece is the folks who find themselves sick enough to be in the hospital, but have a really hard time to actually keep out of the hospital, they keep coming back. And so far, we started a project in September. We now have a really team wrapped around those folks. We've enrolled almost 300 people now in about 2 months. And just to give you one story, this is a woman, one of the very first women we heard about, because she'd been to the emergency department 26 times in the last 3 months. And most of you probably know her at some point. And we said, okay, that's our people. That's exactly why we're here. It took us about 3 to 4 weeks to track her down. She's actually now in a home, and she's actually not been in the emergency department in a month. So, little victories, one at a time, but that's kind of what we're doing, and that's, I think, what the county, and Mission Hospital, through their community benefit is invested in. We also just recently got a Duke Foundation grant to actually expand that work to, again, more square pegs. So, again, thanks for your indulgence, but, yeah.
How does somebody access?
Well, right now we have we're sort of laugh, we call it the 1-800-HELP-ME. It's actually not really that. But we really try to actually create a single point of entry from referrals from any community organization. That if you see somebody says, this person isn't fitting in the system, we've got a number that you can call and we'll get them in. We'll find them and we'll try to get them in.
Okay.
Yeah. Originally, we were just targeting people who were coming out of the hospital. We realized actually that was probably too smallly, we drew that too small. And we've actually found a lot of these folks actually in other places in community-based organizations. So, and we will actually not just create a clinic where they can come to, without an appointment, et cetera. We will go to them. We're actually seeing patients at AHOPE and we even see people in the parking lot.
And one little interesting twist about that is, we do have, in Asheville, we have a medical school campus, UNC. So we have the last 2 years of the medical school for UNC students they can spend here in Asheville. And they are part of this project. So we feel like we are hopefully inspiring new, younger medical students who will become doctors no matter what specialty they're in. Hopefully they'll learn to have a passion for these people and understand them and have a sensitivity to their particular need.
But the idea is to try to create a little mini health system that actually is not us designing a system that they fit into, is for us to figure out how to fit around them. I mean, and that is challenging, but it's actually great work. So.
I'd like to do a safety net.
Exactly.
Well, these are all our partners here too.
So
'cause many of
when
them
there's a
have-
safety net, invariably the net has holes, and invariably there's a few people who fall through. And what we're trying to do is actually be the tape that goes across those holes.
Good analogy.
This is more like a case management model, would you say? Are you using RNs to?
Yeah, but it's case management on steroids. I think all of us actually kind of know how case management works. This is essentially what we're calling actually a transdisciplinary team. In other words, rather than interdisciplinary where everybody kind of does their thing, this is actually putting a team together that actually is in kind of each other's pockets. I mean, literally, this is a team that works simultaneously around the patient. So, again, it's a very different model of care, but it's got to be flexible, and you still are. I suspect that because we've been talking about being person-centered. Whether how do we actually create that? Well, we're going to probably create 500 specific, care plans around 500 patients. So we're not going to design one system that they fit. We're going to probably have 500 models that fit that particular individual. And we have to, because it's not working otherwise.
All right.
It doesn't
Well,
work.
and we're, I'm sure.
I don't think it works.
I don't either. Anyway, and we're happy at the ABCCM medical ministry to have those teaching students at our place and a part of the Project 1300 there as well. ABCCM medical ministry really got started with a group of nurses in our homeless shelter. We found both men and women, but then as we had children living there, just kind of appalled at the health that they were seeing, and foot problems and lacerations and just the brutality of the streets.
we invited Dr. Phil Davis to come for a tour as we talked about this concept of a community clinic. And unbeknownst to me, as we were walking out of the building, out in front of us ran a little 4-year-old boy. And Dr. Davis, with his loving hands, and he was a obstetrician, just said, "Come here, little feller," and picked him up and immediately kind of began talking to him and giving him his own exam right there. And I'll never forget Dr. Davis when he put that little guy down and wanted to know about his sister who was there as well. And he turned to me and he said, "Scott, I haven't seen malnourished children like this ever in Asheville." He said, "Now we're going to start a free clinic." And that's how ABCCM is. We're 277 churches and a little over 5,000 volunteers. And we're at each of what I call the corner posts of the safety net, because our 4 crisis centers touched 1 in 5 persons in Buncombe County last year. Our homeless ministries touched 3/4 of all the homeless. And our medical ministry takes the other half that winches can't take, and we try to fill the rest of those gaps. And even our jail ministry is a partnership with the county sheriff's office. We partner with the county in lots of ways because of that. For example, last year during the heating season, the county gave us, I think, $250,000, $300,000, and the churches matched that. The jail contributed about half towards that ministry, and we matched that. I'm really proud that in 1996, Mission Hospital and St. Joe's then, when they were 2 separate entities, came together and they said, whatever the community and the physicians can raise, because then it was Buncombe County Medical Society, and they continued through Project Access, which was born that same year, said we want to create this strong safety net. And Mission Hospital ever since has said we'll match essentially what you can raise, and that match now for this year is $430,000 for each. To get to Dr. Locke's question, that generates over $6 million in health care for about 7,000 uninsured medical patients and a little over 1,200 dental patients. We serve dental folks. And then in 2003, we worked with the North Carolina Association of Free Clinics and got the laws changed again. Well, I forgot to mention that Dr. Davis and Mayheck's Dr. Dick Olson led the charge with us to get the law changed in North Carolina so that physicians had a Good Samaritan law for coverage. And then I also want to mention that our first office was in the Mayheck Family Health Center from 91 until 96, that first 5 years. So you're hearing how all these partnerships, we're just an example of giving life to those kinds of things where the medical ministry is able to do essentially 3 things and perform 3 roles. Our first role is to help fill these gaps. So when there's some of these gaps, we try to move and expand into those. Our second most important role is to try some of these new things that when the square pegs don't fit, or when the silos say it can only do this much, we try to stretch the arms between those things and develop strategies. I could point to a number of those from the first mobile mammogram programs that we did that led to now BSEP, to the 28806 project that really helped teach us about primary care, to Stephanie Kaiser, who is the grandmother of the pharmacy here, and she helped us found that.
That long ago. The first pharmacy was in a filing cabinet off the side of the bathroom in the Wehe building.
There you go, see?
Don't tell the board of pharmacy. That's where it was. It was
Been so
locked.
many
It
generations.
was locked.
It was.
So in '03, I took what we learned in 1982, and then we helped found the first food bank in western North Carolina called Manna. You know, and then we applied it to medications, and now we're recovering over $3 million in medications. Your free clinic also has the highest level of accreditation. There are 3 levels of accreditation for care, and we meet the highest level and have held that since 2001. So those are some of our roles in terms of filling and bridging gaps. Right now, I haven't talked much about the prescription side, but because of filling that gap, we began filling the gap with folks who came out of the emergency department without enough script or a few days and needed more, to where we're now partnering with Smoky Mountain Mental Health for the last 3 or 4 years on bridging the gap for mental health patients. So they're discharged, and the time between their discharge and they're assigned to a mental health provider and start getting their medication assistance plan or their MAP plan, we're filling that gap with the expensive mental health meds. So somebody asked me why I was still here after 33 years, and I think Jeff and Carlos and others will allude to it, but we really are locked arm in arm, hand in hand, and trying to get our arms and hands around this entire community. And because of everybody in this room, I think we're able to do that, and I'm not sure we could do that in other communities. So it's an honor to serve with you.
Hi, I'm Jim Hardy. I'm the medical director for behavioral health services for the Mission System. And I may not look like it, but I guess I'm the rookie at the bench here. My background is I'm actually a family physician who's worked in community health centers and HIV and homeless health care for 35 years. And enjoy volunteering with Scott and precepting the homeless outreach team. And I guess one of the points that I would accent about that with your question about how do we reach that is that there are some folks who have to be engaged for a while, sometimes months, before they can use the system effectively. And so it's actually putting the time and the energy on the streets to engage them. As mission is, clearly we take care of a lot of unfunded patients and safety net patients. But what we're trying to focus on now, especially in behavioral health, is to improve the way we collaborate with the rest of the system. We can't be a silo and expect to be effective partners. Because we have an emergency room and an inpatient psychiatric unit, we have 58 beds. And at any one time, we have probably 20 to 50 other patients in crisis that need inpatient beds that are in different parts of our campus. And about half of those, now that I'm looking at these, about half of them are homeless. And so it blends in with a lot of the services, and that's why I already know a lot of the folks at the table. But we are trying to do a better job of when we're receiving patients and have stabilized and released patients, that we're now not saying call somebody for an appointment in 2 weeks. Our standard now is for them to have a medication management follow-up in 5 to 7 days. A specific appointment that and we work with our partner agencies and with Smoky and others to guarantee that we can do that, because until then, they were having to wait 4 to 6 weeks after an inpatient psychiatric hospitalization to get in for a medication management visit. Well, that's clearly not a recipe for success. So one of the things is that working with our partners to start doing the things that we know from experience are gonna make a difference for our patients. And some of that has to do also with, we were not engaging effectively with the PATH team, which was already in effect here. So there's a team at A-Hope that does engagement of psychiatric patients that are homeless in the field. Now they actually get warm handoffs from us when we're discharging somebody who's homeless, who's not really fully engaged, who's maybe pre-contemplation or contemplation. We're engaging with them now that the homeless outreach team as well, because that homeless outreach team has a licensed clinician and a nurse on it. There are some patients that are actually better engaged that way. Being also clear that sometimes what they're willing to get treated is their sore tooth or their bad feet, and so, and sometimes you have to focus on that and engage on that before you can get them to treat their schizophrenia. And it's those types of things that we in the hospital have to start recognizing and getting more robust partnerships with the people that we work with. The other thing is that most psychiatric facilities miss cognitive impairment in homeless. And so one of the things that we're becoming a lot more aware of is that there are a lot of folks who pass in and out through the system and are expected to keep up with 8 medicines on an IQ of 65 because the system they've fallen through the cracks in the system. And so both we and our partners in the community, the PATH team and Physical Legal both have SOAR workers that work with disability for homeless. And a lot of the folks who we see chronically in and out and needing these services, not able to engage, part of it's because they have undiagnosed or unrecognized cognitive impairment, or they were diagnosed when they were 12, but it was in a rural area. Mom and dad died, and now they're up in Asheville without that documentation and without any of the services that the system would normally want to be providing. So, and we as a psychiatric institution should be catching that. And so we're trying to be better about those types of things so that we start becoming part of the solution. We're also wanting to work better with our partner agencies in mental health through the LME, but also specifically there's October Roads and RHA and Family Pres, Caring for Children, any number of agencies, and also other agencies like All Souls, who provide certain types of services for certain categories of people that we deal with. The other area that we deal with a lot, because mental health is often mixed with substance use, is working on substance use issues, not only on our premises, but also working with the rest of the community, because there are some significant gaps in substance abuse services that we as a community need to be working on, and we want to be part of that solution. So part of what we're doing then is helping to identify the gaps, because the people that see us in crisis are there often because there are gaps or they've not been able to engage and those types of things. And so we're able to see those gaps, see where we need to advocate for more services, but also make sure that we're doing a better job than we have in the past for connecting to our partners in the community.
Okay, I'm Brooksanne McKinney. I'm a social worker, and I have about 15 years of experience with homeless and healthcare in Denver, Colorado, and Raleigh, North Carolina. And I think the biggest change that we've seen in the last couple years, especially with the behavioral health crisis, and I think Mission has really been trying to not just financially support multiple agencies, but collaborating more to find more solutions, because we know that we can't do it alone, that we have to work together. And so I think it's, this is a testimony, all of us up here, just speaking about this, because we all have to work together, especially with the homeless, but just for other vulnerable populations. And I think since you guys have done such a good job about explaining how we do work together, I think, the emergency room has been the ultimate safety net for many years. And that's where this data is so important, and I think Mission has really tried now to make sure that we share that data so that we can find a solution. And I think just looking at the 78,000 that come through the ED a year, with 2,200 still not having primary care, 450 of those, are people that have primary mental health diagnoses. And I think that really shows that we're dealing with a huge crisis. And so I think that's really caused us to all come together. I think two significant things that just in the recent year that I think are important that Mission's been a part of, as well as the city, county, and almost every agency, is the Oak Hill Permanent Supportive Housing Project. And that project, I sort of volunteered to be chair of that, not knowing what I was getting myself into a couple years ago. But it's really showing how we can help the most vulnerable, and that's actually looking at the high utilizer data for the homeless outreach team, but also across the board in the entire system of the highest utilizers of the Department of Corrections, the ED, and also with mental health. And it'll have 80 units, and 24 of those will be for the highest utilizers of the system that are medically and mentally fragile, and the rest will be affordable housing and workforce. But I feel like that project really shows how we can all contribute financially, but also just professionally to solve a big problem here in Asheville, which the rest of the country is dealing, a lot of cities are dealing with the same thing, but this is an effective way that we can work together. But also just with the behavioral health urgent care development, which the county and the city and Smokey and ABCCM and all the partners were all involved in, and that is a new project that will have a 24/7 place for people to walk in with mental health emergencies. But it's really going to be great because it'll allow the whole community to be in one spot to help these ones that are mentally fragile. And I think that those two projects really show how far we've come and how we can work together to have a broad solution. But I just want to also just say, in the last couple of years, I think it's been really amazing to see how through this difficult time that we can come together. And I just want to thank those that, since I have only been here 2 years, that we have gotten so much done, and I do thank you for all the time and energy with that.
And I'm Jennifer Henderson from Blue Ridge Community Health Services, and very happy to be participating in this discussion. Blue Ridge has about nearly 4,000 patients that live in Buncombe County that are active patients at Blue Ridge. I'm going to give you a little bit of history, and then I'm going to turn some things over to Dr. Dollar, our Chief Medical Officer, and I do have some packets of information that include an annual report. Some history of Blue Ridge, if you're not familiar with us. In 1961, there was a documentary that aired on Thanksgiving. Edward R. Murrow, it was called Harvest of Shame. And I'm not applying anybody in the room who was around watching documentaries in 1961. What that means. But that documentary really, after everyone had just finished a big meal, really helped to highlight what was happening with those who were picking our fruits and vegetables. And the poor sanitation, these were exploited workers, they were our most vulnerable. And so at that time around the country, after that documentary aired, they created councils all over the agricultural communities, all over the country. And in Henderson County, because of the apples, they created the Migrant Council of Henderson County. And it focused originally on education. And the farm workers at that time were primarily African American, Dominican, and Haitian. And the children didn't have education, so they started a clothing closet and an education program. Then President Kennedy passed the Migrant Health Act, and Blue Ridge, which is now known as Blue Ridge, it was the Migrant Council, received one of the first grants under Kennedy's Migrant Health Act. We are the oldest migrant health center in the nation. The one who was a little older than us no longer exists, so we can say we are the oldest and most experienced in migrant health. We have expanded to community health, and even though it's 50 years later, migrant health still remains a rich part of our history, but it's a very small number of the patients we serve, but we're still very focused. We have, the mission is the same, caring for the most vulnerable. We have about 30,000 active patients in Blue Ridge as a whole. Those include patients that use us for family medicine, pediatrics, dental, behavioral health, including psychiatry. We also have obstetrics, and we do have pharmacy, both 340B, reduced price pharmacy, as well as medication assistance programs. No one's ever turned away at Blue Ridge for their ability to pay, and about 56% of our patients this year will be uninsured, and about 24% have Medicaid. So these are people who are living in poverty. As you've heard, we're experiencing the same struggles in terms of caring for these patients, and we know what's happening in Buncombe County, and we've expanded to include a site. We had 3,500 to 3,800 coming prior to our site, and now we've added a new site in Hardin, which Dr. Dollar will tell you a little bit more about. We've always considered Buncombe County in our area, and if you look in your packets, you'll see our service area, and you'll see a dot map that shows every household that has a Blue Ridge patient, and you'll see how we spread beyond Henderson County. I wanted to address the question that came up about savings to the hospitals. When I'm talking to our hospitals in our community, for an ER visit, as an example, just a back of the envelope, for an ER visit, it costs the hospital about $500 to care for a patient that comes in through the ER. If you look at the safety net providers here, 10,000 plus patients, if we didn't exist, we would be those patients would be going through the ER. At $500 each to care for those 10,000 patients, the fact that they can come to a safety net provider saves that hospital, or those hospitals, $5 million right there, just in 10,000 uninsured patients. Now, we all know that patients who are uninsured don't visit the ER only once a year. So you can easily say that by having the safety net that we have, we're easily saving our community $20 million in just ER utilization, inappropriate ER utilization. And then the second thing I wanted to add to that about savings is that from the patient perspective, a patient comes to the ER, it may cost them $1,000. At Blue Ridge and other community health centers, we can take care of that patient's entire care for a year for the cost, for much less than what it would cost. So on average, our costs are about $480 per patient for care for an entire year, about $123 per encounter. And I know other community health centers are similar. So the cost to the patient and getting them attached to a medical home, we're cost effective, we're efficient, and we are accredited as a medical home also. So I'm going to turn it over to Dr. Dollar, who can talk about our clinical programs and about our.
Yeah, so I'm Shannon Dollar. I'm in my 6th year as the Chief Medical Officer at Blue Ridge. Dr. Heck pulled in a patient story, so I'm going to have to tell a patient story. About a year and a half ago, we had a patient come up from the Fletcher, Mills River, somewhere in that area, walked into our night clinic for a visit. She was in her 50s, and I am speaking in past tense. She had noticed a smell, and finally the people at church stopped sitting next to her, and she realized that the pew was empty, and she realized she probably better check it out. And she walked into our night clinic, had not seen a doctor in years. Despite the amazing programs our county's had around breast cancer prevention and mammography services, when she exposed her breast, which is where the smell was coming from, she had a fungating breast mass that had grown through and was, soaked her clothes on a regular basis. And she died within a few months of seeing us. And so that's to illustrate that despite this robust safety net, people fall through all the time. And this is a woman who had worked her entire life in housekeeping, cleaning houses. She was never insured. And she just didn't have the money to see a doctor. And she might have had some trust issues, around the medical world as well. So there are a lot of patients that we need to reach. As Jennifer said, about 10% of our active medical patients travel from Buncombe County. And for that reason, we decided to open up a little plucky satellite location in Hardin about 6 months ago. We're only there 2 days a week, and I have the privilege to call that my clinic now. So I'm going to tell you a little bit about the patients we've served so far. Even though we moved quite a few of my existing panel of patients, because I've been seeing patients for over 5 years, so they kind of followed me down there. We've still seen quite a few new patients. We've had 1,000 medical encounters in under 6 months. 250 total patients, unduplicated patients served, but 115 new patients have been seen so far. 2/3 of the patients are female, and that's not a surprise for anybody probably. The vast majority are between 20 and 65 years of age. 10% are under 20, 10% are over 65. 60% are completely uninsured. An additional 25% have Medicare or Medicaid. So 85% of the patients I see down there are really what we call underinsured or uninsured. We have, not surprisingly, our top 3 medical diagnoses are diabetes, hypertension, and hyperlipidemia. We're seeing an increasing number of Hispanic patients in the last couple months. I think word is getting out in the Cane Creek and Fairview area, and there's a lot of farming in that area. So I'm seeing more and more Hispanic patients who have not had any care at all. I saw a woman earlier in the week whose last pap smear was 6-7 years ago. She couldn't even remember. She'd never had one since she's lived in North Carolina. So we are reaching a new population of patients that haven't been getting care. When we started out there, I did reach out to our colleagues because, as everyone's mentioned, collaboration is key. I called ABCCM and talked to Beth and said, send me your folks south of the county line, the Haywood Respite Program, the Medical Society. I sort of reached out to everybody to say, we'll take folks that are living down in that area that need help. We try to keep all of our satellite locations with equitable care. It's hard sometimes. We have what I call the mothership, in Henderson County, which is our big health center. But we're able to do that at this Mission Party Health Campus. We contract with Party Hospital for labs, which we can do on site. We're working with the Mission Pharmacy. We've reached out to try to make that a contract pharmacy so our 340B drug prices can be extended to our patients there. We're working with Asheville Imaging to try to get the cost down a little bit on imaging studies. Meanwhile, our patients can use our full imaging studies that we have. We have x-ray, ultrasound, and bone density on site at our mothership, so they can still reach that. And they also have access to our integrated behavioral health services, including psychiatry and counseling, and our full dental team as well. We hope in the new year we'll be announcing that it will become a multi-specialty site with OBGYN and internal medicine as well as family medicine. And probably the most exciting part is that in January we're planning to expand to 5 days a week. That the need is clearly there. We're seeing new patients every day we're there. My schedule is now booked out 2 months in advance, so it's time to expand our hours. As always, the patients we serve at Blue Ridge are the patients that I fondly call the unworried unwell. There's a lot of pathology, and patients often delay care because of social, economic, transportation, health literacy, all sorts of barriers that make them access care late, and it provides really a robust learning environment. Already at the Hardin campus, I've had 4th-year medical students from the UNC campus come to me. We serve as a 3rd-year continuity site for pediatrics, psychiatry, and family medicine for the UNC School of Medicine. About a year and a half ago, we were recognized as HRSA's first teaching health center in North Carolina. So we have the family medicine residency program that's at Mayheck's Henderson campus, is split between our 2 main sites in Henderson County. So we have the opportunity to train young doctors and really help them experience community health in the hopes that they'll go out and serve in that same capacity when they finish the program. I just want to say personally, as a graduate of the Mayheck Asheville program, I learned how to be a doctor. I learned how to be a family doctor specifically in Asheville. And so it's very rewarding for me to come back into Buncombe County and be seeing patients and reconnecting with the network of safety net providers that I have gotten to know over the years. So I'm excited to be there. And particularly Blue Ridge is really excited to be able to expand the depths of our services, just like we've done in Rutherford County and Transylvania County and Henderson County. We're glad to be here for y'all in Buncombe County as well.
So it's sort of a shift in thinking about the community care clinics, so now talking about the support services that go as part of that effort for patients that are being seen in those clinics. And so one of those aspects, and you heard people talk about it, is the pharmacy and the access to medication that goes with that. So I'm one of the pharmacists in Mission's Medication Access Program. And it's interesting to hear that idea of training and where you live and then becoming that provider in that community. And that's true for me as well, as pharmacy training within Mayheck and with Mission, and then sort of learning the safety net and being part of that for the last 7 years. What I do, what our clinic is, what our pharmacy is an offshoot of the drawer that you heard Stephanie describe. And so over time,
He's one of my grandchildren.
Yeah, I'm one of the grandchildren. And so you can imagine, you heard that idea of all the barriers, all the complexities in accessing care and establishing that care, maintaining that care, and then a prescription is written and the patient is left with the next step of getting something filled that already was too expensive because they were accessing care within a safety net environment. So what is the role of pharmacists, what is the role of pharmacy in supporting that network of care? And so our big role in that is helping people navigate medication access, the navigation of, it's not, what do you do? I'm arriving with a prescription, I can't afford it, what do I do next? It's a very concrete tether to that patient and that connection to ongoing care that we can kind of meet them there and then use that as a way to kind of bridge them into resources and continue maintenance of those resources over time. So how do we do that? It's all about what you just heard people describe, about that connection within the community and helping that patient navigate the appropriate resource, right? You've heard of a large array of offerings and services, and Buncombe County is amazing for that. So how do you help guide that patient in appropriate use within that safety net? So when a patient comes to us, our first initial step is not, here's the prescription, fill it, and they leave, 30-day supply, thanks. It's understanding the context of that need and how it fits into the rest of the safety net. So if that patient came from Minnie Jones, we're referring them back to Minnie Jones. I don't know what to do there. Well, talk to the social worker, get coordinated. So it's as important for us to understand the safety net as it is for any patient, and just to understand how that whole context works. So Minnie Jones, Blue Ridge Community Health Services, MAHAC, Project 1300, all of those groups that we're coordinated with alongside ABCCM. And so each of us sort of identifying what is our niche, where is that need best met by which group, and how does that come together? And having those continued meetings as a safety net community support group at ABCCM in the lobby to kind of keep that maintenance of that coordination going. So what do we do at MAP? We'll talk with them. Immediate acute need, right? I'm out of something, I need something. We satisfy that need by having an inventory of medicines that are immediately available to take that stress, that pressure, that burden off the immediate moment. And then that opens the conversation in a wider way for really being able to engage the person and thinking about what is that sustainable option for long-term access to the medicine. So that may mean helping somebody navigate complexities of Medicaid, understanding that they may have Medicaid, so using NC tracks to identify that and helping somebody else understand that access for themselves and then guiding them there. Or understanding the nuances of Medicare Part D, coverage gap issues, not having a Part D plan, open enrollment season, both for Medicare and for the federal exchange, guiding people into those avenues and then understanding resources like PISGA legal services to get people there. All the while maintaining that tether of the medicine. It's very nice to have that concrete need because then there's that return and then there's that handing people back off. There's many, many different ways of accessing medicines, and those ways change frequently. So keeping up with those different methods of access is another big part of what we're doing through drug company resources, through mail order resources that are discounted, through other programs in the state, and you've heard people mention 340B as well, using 340B for applicable situations as well. So that's kind of what that looks like. We see about 400, 450, we have that many visits a month. Some of those are face-to-face, some of those are phone, some of those are ongoing. Oftentimes when a patient establishes with our clinic, we're seeing them every 3 to 6 months in support of their care, working with the primary care physician to maintain sort of not just access, but effective, safe use of the medicines they're getting. So when, you heard Dr. Dollar refer to diabetes, hypertension, dyslipidemia, top disease states, all chronic diseases, high medication access needs, managing over time. So coordinating that as well. We have a social worker on staff that can help people sort of think about the nuances of Medicare Part D and helping people kind of navigate their choices within that and the coverage gap that comes with that as well. Yeah, that's what we do.
There's not a lot of people in that league. I just want to highlight.
There's 2 pharmacists, I'm one of them. Autumn's the other. So and Lacey is a pharmacy technician that works with us, and we do a lot of post-discharge follow-up work as well for uninsured patients. Leaving the hospital, social workers, discharge planners will call to see if we have medicines to fill at discharge. And then in the past, 33 months ago, we've been in this, is not just filling for a month and then, see what happens, but within 3 days, a week, 3 weeks, and then ongoing, making sure that patient's connected to the resource in the community. Because as you all know, leaving the hospital and then understanding how to connect with the resource readiness or whatever the barrier may be is real important. So part of justifying our presence is the fact that we're helping contribute to the reduction of repeat ED use that's unnecessary and also hospitalizations. I have handouts if you want them. They're more geared towards patients, but you may have people that you want to have them.
And I have some handouts going around as well. I made extras so some of the folks in the audience can have them as well. I am Robin Merrill, and I am managing attorney at Pistol Legal Services. And since I'm a lawyer, I didn't come up through Mayhew, but I was born at Mission Hospital. So there's my connection. And many of you may be wondering, what does lawyers and law have to do with access to health care? So I'm going to explain that to you. And let me tell you first that Pistol Legal Services since 1978 has been providing free civil legal assistance to help low-income people meet their basic needs. And what that really means is we help out on civil cases and we help low-income people, and we don't charge them for that help. One of the main facets of our program is our Access to Health program. And it's also our fastest growing. And we help people with healthcare issues pretty much in 3 major ways that I'll tell you about. The first is our SOAR program, the second is our HEALS program, and then the third is our Navigator program. SOAR, which is like SOAR like the eagle, not the other kind of SOAR, stands for SSI, SSDI, Outreach, Access, and Recovery. And many of you may know that the process for obtaining disability benefits can take years, and that people really suffer during that time of limited income or no income. And SOAR is a specialized process that is for people who are homeless or at imminent risk of homelessness. And they kind of get to bypass a lot of the bureaucracy. And SOAR is designed to help them make better applications that then go to specialized folks at the Disability Determination Services Office in Raleigh. And so instead of waiting 2 to 3 years for disability, these folks know in 3 to 6 months. And they are approved at a much, much higher rate than the regular disability applications. So, and we are seeing an average of 3 approvals a month. So that's 3 homeless people who go from having no income to having at minimum SSI level income, and some of them have worked enough to have SSDI as well. And as you probably know, the truest benefit, the greatest benefit behind having SSI is that it comes with Medicaid. So that means healthcare can get paid for. And, which is why these medical providers like us. What can we say? But, and we've been doing this for a few years now, and there are more success stories that I can share that I can think of, but I want to tell you about this one person because he's so Buncombe County. He was living out in the country, near his friend, in an old shell of a little travel camper. No heat, no electricity, and no running water. And he'd been living there for several years. He was illiterate, he couldn't drive, but he was a proud mountain man, as we all know, and asking for help was very, very difficult for him to do. And even after he found us and we began helping him, he didn't want us to know he couldn't read. And he didn't want us to know he couldn't drive. But we did figure those things out. And once he was approved and he got some income, he got a better place to live. And he got to go to the doctor and get his multiple issues treated. And he came back in to see us, and we almost didn't recognize him. Because, one, he cleaned up, he shaved, got his hair cut, but he was just more robust and healthier and happier, and still living out in the country near his friend, but in a much better place, and had that SSI to help him make it. You know, and that's the kind of folks that I, as a mountain person myself, am really proud of that we get to help. So much of the work that we get to do with these other organizations at the table is through the SOAR program. Everyone has spoken a little bit about the homeless. And we've been in the forefront of assisting with homelessness for a very long time. Mandy was on the committee to help me, but we created and wrote the 10-year plan to end homelessness back in 2004. And we've seen great success because of the many partners around this table and many others where we have worked on providing housing and services, much of those services, medical services, to those homeless people. And their lives are much longer now because of that. The HEALS program is our partnership with medical providers where we don't do the access to healthcare so much piece, but the other piece, those things that are the social determinants of health, where maybe somebody is at the hospital and they're there because they got beat up by their husband, and we can help with the domestic violence piece of that so that they can live without the fear of physical harm in their home. We also help much with the housing aspect of it. There are a lot of people in this community, though, although they're not homeless, they're not living in decent housing. It may be cold and drafty, it may be moldy, there's 1,000 things. And we all know that people who have safe, affordable housing are healthier than those who don't. So that's the sort of thing that we are trying to help with through the HEALS program. And it gives special access to medical providers to call our staff directly so that we can get those clients in. And then there's the navigation program, and that's about signing people up for coverage through the Affordable Care Act. And what an incredible, incredible opportunity this has been, and truly life-changing things that we are seeing from folks. We have about 5 or 6 navigators on staff. This year we had 52 volunteer navigators. We are operating in multiple locations in all 6 of the counties that we serve, Hardin being the largest. We had a kickoff event with some of the partners here at the table at the Civic Center on the 15th, where there were 55 appointments and over, I think, 100 people served through those 55 appointments. I know one of our navigators said that of the 5 people she saw, they qualified for premium tax credits of over $25,000. So what the Affordable Care Act is able to do is to provide people with health coverage in a way that they can afford. And what we are finding to be the great benefit to the community of this navigation project, because really anyone could go to any insurance broker and pick out a plan. And for some people, that's a good thing. But there are folks who've never had insurance. They don't understand how it works. They don't understand the purpose behind it. They don't know what a copay is or co-insurance or premium, much less a premium tax credit, or what additional benefit they may have if they're between 100 and 250% of the federal poverty line. So our navigators all receive extensive training where they're able to take the time to go over these things with people, and then because we're required to be neutral, we really help them find the plan that is best for their healthcare needs. And we're not pushing them toward any company or plan. Because of just the staff that we already have, we're able to offer Spanish-speaking appointments. We're doing a great deal of public education activities. We, this year, have learned about the SHOP, whatever SHOP stands for, small business something, something, something. But that's for the employers that have less than 50 employees and who can help provide coverage for their employees through the marketplace. So it's, this is our 2nd year with the navigation project, and really it's kind of turned our office upside down, but in a very good way, as we've all learned how to serve this whole new number of people in a whole new way. And I have a story. And this was just a very quick story that last year, one of the people who came for a navigation appointment had a chronic back problem that was so severe that he had to lay in the floor during the appointment while he was being assisted. But the great benefit was that he was assisted, signed up for health care, and about 2 weeks later began receiving it. So while we're not really allowed to follow up with those folks, we have great hope that he received the assistance that he needed now that he had health insurance.
Good afternoon, my name is Christina Hardin, and I'm the Chief Operating Officer for Smoky. And this is a very humbling activity that y'all have set up today, so quite a privilege to be here. So I'm going to give a little sort of 30,000 foot level of Smoky and then drill down to Buncombe County. So for many of you, we might be a new partner. Your historical LME MCO, of course, has been Western Highlands, and if you've been watching mental health on the sidelines, it's a quite interesting place to be. So we had the privilege to come into Buncombe County and the Western Highlands 8 counties, total fully merged and consolidated on October 1st, 2013. But Smoky serves the 23 most western counties in North Carolina. I think for the board members, I brought you a packet, and there's a PowerPoint presentation with a nice little colored map kind of outlining who and where we are. So today, we're serving about 1.2 million people in those 23 counties. On any given day, our average monthly Medicaid eligibility is running about 167,000 plus people across the 23 counties, and basically that means that on any given month, 167,000 people are walking around with a Medicaid card in their pocket or wallet or something. Our average number of consumers that we are serving, we treat people who have or provide contractual services, I should say. We do not personally provide any service. We are a local management entity and a managed care organization. And what that truly means, on the local management entity part, we receive about $45 to $50 million a year to provide services for people who cannot or are not eligible for Medicaid. We do not really do very much at all with Medicare, and sometimes that's very confusing for people in the system. So overall, our budget's about $350 million completely. So we have, Smoky itself started out in the 7 most western counties of western North Carolina. They've been around for 39, soon to be 40 years. So they're an agency that has a long-standing history in western North Carolina. We do manage people's care from age 3. We do not manage the care for a Medicaid individual or uninsured from 0 to 3. That's sort of the way the system is set up. But from 3 until when they may no longer need any of the services for mental health, substance abuse disorders, and intellectual and developmental disabilities. So we are a managed care organization. We are one of 9 in North Carolina, soon to be one of 8. Some folks out east are merging here by next July 1st. So when we as a public system, which we are a public system, we're local government employees, and we truly, the people that I have the privilege to sit at this table with today, are truly, we are all in this together, and I just feel such a commitment from people in any conversation or meeting that I'm ever in. And I will say that Buncombe County is quite unique in what you have done here, not only based on the population of people that you have, but just it has been truly a jewel for Smoky to be able to come in and even be considered to be part of a community like this. And I say that very sincerely on behalf of our board, which Angie is part of, and our administration of Smoky. So becoming a managed care organization in the public system, it makes us very different in North Carolina. I've just been to Washington, D.C. to sit on a couple of policy committees in San Antonio to look at integrated care in some disability areas. And when I talk about we're local government, people just kind of roll their eyes. Well, how can you be a managed care company and be local government? But we are in North Carolina, and our great General Assembly did make that decision, and I thought this is my 36th year in the system, and I love Western North Carolina, born and raised here, and I think this is a wonderful, wonderful place to be. Great things are going to happen. But a couple of things that I think is really important. As a managed care organization, we truly have some very specific commitments. One of the commitments is a waiver that we are highly scrutinized, audited on, and measured on is access to care, which you can see is taking every single one of us to improve access to care. Improves quality of care of the number of people we are serving. Again, typically in any given month, we're actually providing services. We contract with 723 providers, and in Buncombe County alone, we have 72 providers that provide services to people who are adults with mental health and substance usage disorders, 81 providers who serve children with mental health and substance use disorders, and 159 providers in this county alone for individuals with intellectual and developmental disabilities. So out of the 723 for 23 counties, you have that many providers that we have contracted with. Smoky has a very specific model. We do this very differently than some other managed care organizations, based on which all of us are very aware of and that you're probably learning more about today, is the number of people that are uninsured. And for us, in all our 23 counties, but especially in this county, people are truly coming out of the woodwork. Our numbers, I just hired approved 5 more positions just for Buncombe County site. You may know our office, which we're very privileged to have through the county at 356 Biltmore Avenue. We have 169 staff there. Now, some of those are backroom functions for us, but a lot of that is the staff who live and work in this community doing the services or the administrative functions that we are required to do based on a managed care organization. So we have a large presence here, and we should. But the other thing that I think is important, see, I got music in my presentation, is that we have a local presence in every one of our 23 counties. That is another thing that makes Smoky very, very different. We're either in with DSS, Department of Social Services, DJJ, we may be with a particular provider, or we may have our own office. Among the 23 counties, we have 4 regional offices, and of course the office here in Buncombe is our administrative office as well as one of the regional offices here. We have one in Silva, one here in Asheville, a large office in Lenore, and 2 large offices in Boone that serve our northern region. So we do, you know, when I think about what we are doing is that we are really trying to be honest with you, catch up with the demands and the needs of this particular community on every given day. As being part of the system, but new to this particular community, and meeting all these people in the last 18 months, understanding how your system works, building all the relationships and partnerships, we have been extremely committed to do that, not only in Buncombe, but the other 7 additional counties that we acquired on October 2013. Just a couple of other numbers to kind of talk about in regard to who Smoky is. On the average, and again, we all probably have a variety of numbers here and how we look at numbers, but on the average, we're seeing that are part of our system, 445 consumers are going to the admission emergency room. That was most likely one of the consumers who one of our providers either should have been involved with, be responsible for, or had something to do with either prior to that emergency or definitely after that emergency. We contract with RHA to provide mobile crisis 24/7, 365, a team of people that do that. Just in Buncombe County alone, each month they're going out 90 different places. It could be somebody's home, it could be them at a shelter, it could be at a provider office, it could be at a gas station, wherever the person decides that it is a safe place to meet them and they would like some assistance or help in their crisis. And that mobile crisis team will go out and assist in some way. They may or may not go out with law enforcement. They may go out with, and have some family member meet them, and then when they get there, they'll do an assessment and decide the next steps of what to do for someone. We have a very large, in each of our counties, another big cost ticket for us at Smoky that we're very committed to is what we call a walk-in center. We have a walk-in center in every one of our 23 counties. We have one here in Buncombe that's run by RHA. Over the last, I'd say 6 to 8 months, we have encouraged them, required them, and they have truly delivered in hiring probably about 20 to 30 additional staff to meet the demand, to have more hours, longer hours, and to be able to have open times where the things that Dr. Hardy and Brooksan and different people have spoken about, that they just sort of hold times on people's schedules so that if somebody shows up and they really could just benefit from some outpatient med management, seeing somebody today, they could refer to that. Neil Dobbins, that has been a very supportive program by the county and many other partners here in the community, are seeing about 153 people a month for crisis services there, and they're averaging way over 90% occupancy, which has been absolutely wonderful to help all of us in this community. There's been 172 on the average law enforcement drop-offs, either at Neil Dobbins or Mission ED, which I'm sure the county is extremely supportive of. More than 50% of all the ED experiences that we know about are involved in with many of our partners. 50% are homeless, and they're truly at that poverty level that we've all spoken about today. And the one thing that we continue to see that I think we all struggle with is just the continued large increase of the need for substance use services around our providers and just overall building that capacity. And we're really trying to take some very strong initiatives in the next year to try to provide that more and look at the workforce issues for the providers so that more can be provided to people. A couple of people have talked about several initiatives that I think is like what's going on now or going on is going to be the future that we're probably all going to get into, all about integrated care, whole person care. We see ourselves at Smoky truly as part of the healthcare system of the western region of North Carolina. We don't see ourselves as a specialty little carve-out entity over here as the public system has been for mental health, substance use, and developmental disabilities, because to me, at the end of the day, we're all serving the same people. We're all trying to figure out what to do and how to collaborate and what's the most cost-efficient way to do that. and I think that, you know, we are really, I'm sure all of us are very committed. Among the 9 NCOs, since we've been all up and going over the last 2 years, $153 million has been saved. Now, the great thing that's most important that all of you should know is that based on the waiver that we are working under with the federal government and the state of North Carolina, every dollar saved must go into services, which I think is a phenomenal requirement, phenomenal. And this past year, Smoky put over $2 million additional dollars back into the service delivery system and trying to meet needs. And again, it's across the 23 counties and trying to look at where are our priorities and what do we need to do. Just end on a couple notes. You heard many of you have been involved and contributed financially with manpower at the Buncombe County Medical Health Fund, the 1300 project that Dr. Crane talked about. We are providing the funding for a nurse to be part of that homeless team. We're so excited, and just a great experience going on there. To me, that's a really learning laboratory. One of the new things that we will be the first to do here in Buncombe County with great collaboration with MAHEC and a physician in our community is we will have a medical health home for people with intellectual and developmental disabilities, which will be the first of its kind anywhere in North Carolina. And we are extremely excited about that. In the Smoky 23 counties, and a piece of that has to do with some people living here in Buncombe County, is we have, for some reason, the largest number of medically fragile people with that disability than anywhere else in the state, which is really interesting. And so when we listen to all of this medical care, we truly represent, all of us represent a group of people who are really going to need some. And then Brooks Ann and Dr. Hardy, I think, talked a little bit about very exciting news, and I know some of us are going to meet later on this afternoon, to open the building we are in. We're currently in at Smoky. We are moving out of that building, and we're going to move out to Ridgefield. And that building is going to be, there's been a design team that many great partners here have been part of to build a behavioral health care urgent care center that Brooks Ann responded to. That will have 16 beds of facility-based crisis, a living room model, a number of lounge chairs that people can come in for 23 hours of observation, maybe get their act together, and we're going to have peer support. And it's going to be just so, as she was saying, so many great things are going to be able to come into that building. And what, of course, the ultimate goal there is that all this ED admission data that you hear here, admission, that between this, the walk-in center that we have with RHA and all the additional services and dollars we're putting into that, as well as the behavioral health care urgent care center, our goal is this has to change, and we are committed to make a difference. And I think so. This is really, really exciting, and I think that a lot of people will benefit from that. And our goal is to help everybody else meet their goal. And so, very much, thank you so much for an opportunity to talk to you today. Thank you.
I'm very honored to be here too. I am Maureen Schwartz. I'm the CEO of the Western Carolina Medical Society, formerly the Buncombe County Medical Society. I'm going to be passing out an advertisement that we place in the Asheville Citizen-Times once a year. And I know that the print is really tiny. I wish that each piece of paper came with a little magnifying glass because people really want to see who's on here. If you take a look at this, this really represents a public-private collaboration between a lot of everybody sitting at this table in the safety net, as well as private physician practices and other entities that come together to help support the uninsured. What you see here is a list of all the physicians who volunteer to provide healthcare services to low-income uninsured patients in Buncombe County. Project Access was developed back in 1996 as a response to a local problem, which was that patients being seen in primary care were having great difficulty accessing other services such as specialty care, medications, durable medical equipment, labs, radiology, you name it. So if a primary care physician wanted to do his or her job well and develop a good treatment plan with, really focused on the whole person, and that primary care physician handed that treatment plan over to someone who had no resources and no knowledge of how the healthcare system worked, what do you think the likelihood would be of success? This frustrated primary care providers to no end because they could not make a change in the patient's health, and they were spending a lot of, I know y'all are looking at your doctors, by the way. I've seen this behavior. It's okay. And let me know if they're not on there. You know, we just heard stories about people who could not follow through on their care. And then the physicians and their staff spent innumerable hours on the telephone, calling up all of these other providers they needed, trying to see if they could get just this one uninsured patient in, please. Well, that's a huge waste of resources. It's very ineffective. And at the same time, the independent physicians and the specialists were actually seeing uninsured patients in their offices, but they weren't necessarily the same uninsured patients. They might have come to them a different way. So our thought was to better coordinate who gets referred from primary care.
You're not available. Connect to the internet.
I'm hearing voices.
Christina, you have voices.
Okay, let's see, where was I? Our goal was to harness the volunteerism that was already taking place in the community. I mean, it was all over the place, but it wasn't coordinated.
Yeah.
So the whole idea here is to funnel patients through Project Access. The county supports Project Access to be able to screen and evaluate patients for eligibility. And I'm not going to go into all the details, but just know that we have a number of criteria that they need to meet, and they have to demonstrate that they meet certain income levels. And then we will help them gain access to specialty care, to labs, to radiology, medication, durable medical equipment, and interpreter services. We actually have a whole interpreter services program at the Medical Society where we can offer services to limited English-speaking patients and deaf patients in over 15 languages. So we are really trying to support the delivery of care in the safety net system by offering access to a part of the healthcare system that was not well coordinated and difficult to access. You'll also see on here that we have participants from the non-medical community, non-traditional community. We have acupuncturists, we have chiropractors, optometrists, and physical therapists. And all of these folks have come to us because they want to give back to their community. They understand how important volunteerism is and how important their services are to improve the health of our community. So I'm very proud of that, and I'm also proud of our relationship with our safety net clinics. It's a privilege and an honor to work with the safety net folks around the table. One of the things, so I will say that on an annual basis, we are staffed enough to be able to see about 3,000 patients and get them through the system. And we keep track of the value of services that are provided. And then on an annual basis, that value is approximately $8 million. So we're able to leverage philanthropic care into a real service and a tangible result. Now, as the Affordable Care Act evolved and we saw that the health insurance marketplace was developing, we recognized that a good number of our patients fell into a category of federal poverty level that would allow them to actually go into the marketplace and sign up with subsidies. Now, as you probably know, if you're too poor, you don't get those subsidies, and you can't afford insurance. But if you're kind of poor, you get access to the insurance marketplace with subsidies. So we actually carved out a subset of our population and did in-reach into our Project Access population to move them out of the volunteer network and into insured care. We participated in the first open enrollment, and we were able to sign up over 80 people. We now have cross-trained all of our staff at the navigator level to be able to be a one-stop shop for low-income uninsured. So now a patient can come to one of our health access counselors, get evaluated for eligibility into the insurance marketplace, eligibility into Medicaid or Medicare, or if none of those are a fit, then they are able to be evaluated for Project Access. So in order to push out these services into the community and make it much more efficient and convenient, and in order to better integrate care, we started co-locating at the Western North Carolina Community Health Services a couple years ago, and that has worked out brilliantly because our staff member is now really a part of that team and works very effectively over there, and patients don't have to try to get to our office. It's truly one-stop shopping. And he's also bilingual, so that helps very much. So we looked at that model, and as the 1300 project started to evolve, we thought that this same thing would be helpful for us to outsource one of our health access counselors to the 1300 project so that we can do the same thing. We can help patients on site with their access to either insurance, public or private, or in Project Access. We started, I think, I don't know, maybe a week ago, week and a half ago, so that's a very new effort, but we believe that that co-location will be very important as well. In terms of the future, well, the other thing I do want to say is that in terms of serving the county, between the Western North Carolina Community Health Services and the health department, those referrals account for between 80 and 85% of all of our referrals. So we really are focusing on helping the Buncombe County commissioners and citizens with improving access to care at those important sites. The remainder of our referrals come from our other safety net providers like ABCCM. Private physicians actually participate in Project Access as primary care providers. And we also get referrals from Blue Ridge for patients who are living in Buncombe County, as well as Hot Springs, which is another community health center in Madison County. So all of that is to say that we want to continue to provide those services with co-location as needed. We think that this kind of access to care for the uninsured is going to be necessary, even with Medicaid expansion, if and when it happens, because we have people that are moving in and out of systems, and there are always gaps in care. We also have patients who are exempt from having to meet the insurance mandate for a variety of reasons. So in some form, I think that Project Access will continue to be needed in the community, perhaps in a smaller way, and we actually hope for that. Our goal is to not be a huge enterprise. Our goal is to fit the current needs, and we hope that those needs really narrow as expansion takes place. That would be a good thing. Thank you.
And thank you all for sticking around to hear from CCWNC. I appreciate that, and I'm also very, very happy to be part of this panel and to work with all of these folks at this table doing great work. And Annie Carpenter is my name. I'm a Health Net Coordinator with Community Care, Western North Carolina, which of course is one of the 14 statewide networks providing
care management services, pharmacy services, and quality improvement services for a network of providers and our partners, community partners across an 8-county region. I will go ahead and pass out some information that I've brought as well about our network and the safety net services we provide. That's a big stack, so. In terms of Buncombe County specific projects that we have going on, obviously Medicaid patients are our largest population for whom we primarily provide care management to targeted Carolina Access 2 patients. There's 40 providers in our Medicaid network area in Buncombe County alone. We have 18 full-time care managers, team leaders, and support staff assigned to this population in Buncombe County, which is about 33,700 patients in the Medicaid network. 7,214 of those being in the age, blind, disabled category, while 24,629 patients are in the under 21 category. So we have a pretty expansive pediatric service in our network, and 2,053 of those eligible for health choice services. Additionally, and I'll touch on some of the more specifics as well, we have right now 1,257 Health Net enrolled uninsured patients in our network as a way to, like Miriam said, be able to truly be that safety net for patients that are going to cross systems, because there is an element of churn that's going to happen between Medicaid and uninsured for a variety of reasons. So our Medicaid services include pediatric services and health check coordination, care coordination for children, also known as CC4C. That's for the 0 to 5-year-old population. We have pediatric care managers that work in our provider practices, the Child Health Accountable Care Collaborative, or CHAC for short, which is transitional care and working with Mission Hospital for medically fragile children. The pregnancy medical home designation is in all but I think 2 OB practices across Buncombe County, providing also OB care management services through there. And of course, as a part of our Medicaid services for our provider network, we have medical management meetings and practice manager meetings where we relay information about Medicaid services and changes that providers need to know about, as well as bring the voice of the provider back to our partners at the state level. So pretty important work going on in the Medicaid world at CCWNC, and luckily I've seen for the past 6 or 7 years now really an emphasis on ensuring that we include uninsured and underinsured patients in the mission of our organization. We have participated with the Health Net statewide network and received funding from the Office of Rural Health to reach our safety net provider partners in our network area. We provide currently regional population management for uninsured patients. That's disease management protocols and care coordination, access to community resources, as well as we've had a long-term project going with Mission for ED high utilization as well, working on a lot of the same outcomes that our partners have recognized as well to be important. We've seen some good success with our patient panels being able to reduce their utilization in a 3-month time period after enrollment with a care manager, where we look for linkage to primary care home, as well as identifying patient-centered needs, using motivational interviewing as a tool to help inform the care plan that a care manager can follow with them across the healthcare continuum and until their goals are met. We have additional infrastructure and services available through community care that include some expansive behavioral health programming, clinical pharmacy services, and PharmDs available to do medication reconciliations and consultations with our providers. We have a lot of QI initiatives going in our practices, as well as an EHR specialist available to help practices with meaningful use. We have a team of practice liaisons throughout our network area that communicate with our practices regularly and help convey the messages of CCWNC and make sure that our care teams that are engaged with the practices are meeting the needs of the practices and providers. And we also have a palliative care programming, long-term care programming. We're working with the adult care homes in Buncombe County as well around transitions in care and services for vulnerable populations. So we are doing a lot of work at CCWNC and certainly couldn't do without the partnerships. Our key agency values include collaboration as one of the most prominent ways to impact and affect change in the healthcare system, and so we have valued all of these partnerships over the long haul and continue to do so. Smoky Mountain Center and CCWNC have become great partners in terms of the LME and the behavioral health needs of our shared populations. We have regular patient staffings between care coordination teams to get down to a patient level of what needs to be done and how can we together wrap around these patients and make sure that their medical and mental health needs are met. We have certainly used the access referral system for linking patients to behavioral health needs as necessary, and we participate on the Smoky Provider Advisory Group, the Subcommittee for Integrated Care, and have membership on the Crisis Response Task Force. So certainly working together in recognition that behavioral health is a key component to whole person health and the needs of our safety net patients. We have a lot going on with Mission as well, and with CCWC staff embedded for Medicaid transitional care and the ED on inpatient floors in COPSTEM and in the NICU. We have CHAC, again, that's the Child Health Accountable Care Collaborative Project. Staff for that program embedded in Mission's Children's Hospital and Asheville Cardiology. We have EHR and HIE access for coordination with hospital, specialty, and primary care throughout our network area. So really across that continuum of care, being able to communicate with providers to enhance the knowledge base they have about their patients and their social determinants, to be able to help convey and emphasize and re-educate about the messages providers are wanting their patients to get that sometimes is difficult to get in that short office visit. So reinforcing care plans with the data from the EHRs. We have also been participating in the WNC Patient-Centered Medical Home Project, knowing that the patient-centered home model of taking a team approach, just as we are doing as a community, is being done in the practices as well, and helping to inform that because of our long history of coordination and care management, and knowing really how to be, as an old colleague of mine would say, the queen on the chessboard who can go in all those different directions that are needed in order to help the patient move along in their health goals. Certainly, Buncombe County and the partners here, and you all, and the work that's being done in Buncombe County, we are happy to participate with in multiple ways, including working with the Buncombe County first responders, fire, police, and EMS on the use of naloxone rescue kits as a protocol. Certainly the Buncombe Safety Net Committee, which we're all here today and meet regularly to discuss the gaps in care and the new opportunities and innovations that can really impact the populations we're all sharing and trying to serve. The Buncombe County Health Improvement Plan and perinatal safety net meetings all have representation from CCWNC staff to help not only inform steps forward, but also plug our services in where we can be of use. Innovative approaches in the pediatric collaborative, foster care, well-being initiative, as well as contracts with the county for OB and CC4C care management services. So we're grateful for all of those opportunities to impact patients and a personal level to develop the relationships that you guys all spoke so well to today, that really are the key to driving change on a personal level, but also to sit around tables with you at administrative and community levels to strategize and get creative and to think about what we can do together to improve healthcare for the most vulnerable. So.
Thank you, Annie. I appreciate that. Thank you so much to the panel for, as you can see, the safety net is a huge, medical safety net is a huge endeavor, and I am grateful to you for your sharing of the information. I appreciate the board for taking the time to hear that.
Thank you. I'd like to say to the panel, thank you so much for your time and for your dedication to what you're doing. We are very appreciative, not only from this board, but from the people within Buncombe County for the services that you provide. Scott, I wanted to say amen after you finished, but I figured that you feel like home at something like that, but I didn't do so. For those of us who have been around to see people like your organization grow, the decisions that were made here in Buncombe County to do various things, we're very appreciative of what y'all are doing, and thank you so much. I would like to remind the board that on our next meeting will be on December the 19th because of the Christmas holidays, and I also have a story to tell. We don't have a quorum, and therefore I'm dismissing the group. Thank y'all.
No?